Hi, so coming up is Dr. Catherine Varner from Mount Sinai Hospital, and we're going to hear a little talk on postpartum management or patients and so forth. Thanks.
So I just want to start by saying what a gift this is to us to be here as a community together, and thank you to the conference organizers for making this possible. I'm thrilled to be here and honored, certainly. And before we start, I have no conflicts of interest to disclose. I do receive some research funding, and I want to start the talk by sharing with you that just before the pandemic, the WHO and the CDC described the increasing rates of maternal morbidity and mortality in North America as a crisis. And certainly, as we look to our southern border in the last 48 hours, the state of reproductive health in North America is quite precarious. We've done, in the last 3 decades as a society, a very good job of looking after neonates. And in fact, their rates of death and morbidity have decreased substantially, but we have not done as well by their mothers. And in fact, comparing to their own mothers, North American women today are twice as likely to die in the peripartum period. This is from a variety of factors: increasing comorbidities as people reach their reproductive age. We also see women having children at later stages, and we see inequity in how people can access care, certainly in the United States, probably less so in Canada. And women of color are disproportionately bearing this burden. A Black woman in the United States is 3 times more likely to die in the peripartum period than a white woman. An Indigenous woman in Canada is twice as likely to die in the peripartum period than a non-Indigenous woman. We are now part of this story. And the reason is because the time that women are in hospital after a delivery is so short. 24 hours for a patient who's had a normal spontaneous vaginal delivery, and around 72 hours for someone who's had a C-section. How many people have been on a postpartum unit in the last 10 years? Quite a few of you. So it is like a terrible summer camp to learn how to look after a baby, how to wash the baby, how to feed the baby, how to put the baby in a car seat, how to not shake the baby. At 24 hours, a bilirubin is done, and if the baby's bilirubin is fine, then you go home. There's very little attention to the mother. So it's not surprising that we are part of this story. In the first 7 days, we see a huge utilization of the emergency department by postpartum women. And in fact, in Ontario, the vast majority of the times that people in pregnancy use emergency departments are at times when ambulatory obstetrical care is not otherwise available to them. That postpartum visit is quite conveniently 6 weeks after the delivery. All of the action has happened. And in fact, if you look across North America, people are far more likely to be in the emergency department in the first 10 days postpartum more than any other time in that first year after they've had a baby. The vast majority of hospital readmissions are going to happen in that time. So emergency care providers are now postpartum care providers. So we need to know what can kill and what is most likely to kill this population. There are 4: postpartum hemorrhage, PE, maternal sepsis, and eclampsia, and other hypertensive disorders. Today, I'm going to talk about maternal sepsis and eclampsia and other hypertensive disorders, because these are the ones that are most prevalent, these are the ones that are on the rise, and these are the ones that we are most likely to miss. But before I go into the bedside management of eclampsia and sepsis, I want to go through just a few of the things that I do at Mount Sinai Hospital, because we see a lot of postpartum patients in our emergency department. We have 6,000 deliveries in our hospital per year. Many of those patients are sick. These patients, if they're in their first week, they have a baby that needs to feed every 2 hours. If they're exclusively breastfeeding, we need to make space for these patients to feed in our department, and that space cannot be in a waiting room. It cannot be in a chair. If the baby is at home and takes a bottle, we should be offering them a breast pump. In our hospital, we have the handheld disposable Medela breast pumps. I no longer use the terminology pump and dump when I'm looking after patients in my emergency department. I tell them within the first few minutes of seeing these patients, every medication I'm going to give you is compatible with breastfeeding. And that includes IV contrast for PE studies. The American College of Obstetricians and Gynecologists says that it's no longer required to pump and dump after IV contrast following a PE study. These patients look tired. They're exhausted. We often see them in the first 48 to 72 hours after birth. It's hard to differentiate who is sick versus who is not sick. So I encourage you to use a clinical decision tool to help you sort that out at the bedside. The clinical decision tool that I think is most useful for our purposes in the emergency department is the Modified Early Obstetrical Warning System, also known as MEOWS. MEOWS has been widely validated and adopted in the UK, parts of the US, Australia, and has had a couple of validation studies done in Canada. The limitation to our field is that it's not yet been validated in emergency departments. But what it is, it's all physiologic parameters that we collect at triage. This tool can be used by any member of the healthcare team, and that's in part why I really like it, because it can trigger any member of the healthcare team to say, this patient is sick. One red trigger or 2 yellow triggers means that this patient has a higher risk of severe maternal morbidity, ICU admissions, and death. It's not perfectly sensitive, so it can still miss those PE patients, for instance. It can still miss that early septic patient, but it's the best we've got so far. In places like the UK, this type of tool puts a patient into a specific algorithm. This is one example from Scotland. And much of the focus for these patients is about sepsis and excluding sepsis and treating them early, because it's one of the most time-sensitive conditions that we have, and it's one of the ones that's most prevalent, causing maternal morbidity and mortality today. So let's talk a bit about a case of sepsis. This is a 37-year-old G1P1 who delivered at home. She's presenting 4 days after her delivery, and in the first 2 days it was great, things were going well. In the last 2 days, she hasn't been out of bed. Everyone keeps telling me that this is normal. I haven't been out of bed in 2 days. Not getting out of bed in the postpartum period is not normal. When you take a look at her vitals, her blood pressure is 85 on 50. She has a red trigger. This patient is sick. On her abdomen, she's tender, and she has foul-smelling vaginal discharge. For this patient, it's not surprising that her source of sepsis is postpartum endometritis. But for the undifferentiated septic patient, you've got 4 W's of the most likely causes of sepsis: womb, postpartum endometritis; water, UTIs; wound, that could either be the C-section scar or the episiotomy site; and wind, pneumonia. The good news about the treatment of these patients is that it's very similar to the treatment of any other adult patient with sepsis. We're going to get cultures early. We're going to start antibiotics early. We're going to give them fluids early, and our vasopressor of choice is norepinephrine. Where it gets confusing are the drugs. There are a few reasons for why that is. These patients have been recently hospitalized. It puts them into the bacterial milieu of the hospital. The patients also have a soccer ball in their abdomen, and if it's infected, source control is critical. Picking the right antibiotics is critical, because they can get sick so quickly. Most often, the bugs are going to be E. coli, strep, and some anaerobes. And about 30% of these patients will have a polymicrobial source. So let's talk about antibiotics, where it gets confusing. For patients with postpartum endometritis, the treatment will be AMP-GEND. If they've been instrumented, either with a high forceps delivery or a C-section, you're going to add Clinda. For UTIs, it's Amgen. For wound infections, remember these patients have been in hospital recently, Pip/Tazo and Vanco. Most of these patients are coming in from the community. They're going to have likely community-acquired pneumonia. If it's very near to the time of hospital discharge, then we're thinking hospital-acquired pneumonia. But for the vast majority of our cases, they're going to be ceftriaxone and azithro for pneumonia. If you're not sure, Pip/Tazo, Clinda. Let's talk why Clinda. 5 years ago, there was a cluster of group A strep infections in Ontario's hospitals. These were devastating. They killed several mothers, and several mothers survived. This was an excerpt from one of the media outlets during that time, and the bottom quote was, "I kept shaking. I couldn't even pick up my baby. When I got to the emergency department, they gave me antibiotics for what turned out to be a strep infection." That emergency team that day saved this patient's life. Invasive group A strep is incredibly morbid. And the problem is it's hard to pick up when they first start showing symptoms. Constitutionally, they may look well, but they don't feel well. They describe being tired. They describe being low energy. Only late in the game do they start getting high fevers. But 50% of these patients progress to septic shock. 50% of those die. Clindamycin is the drug of choice in these patients because it decreases the exotoxin release, which is so deadly in these patients. And if they end up in the ICU, then we consider high-dose IVIG. Not every patient, this is a rare condition, but not every patient comes in, is going to have group A strep, but you've got to think about it. Does this patient have a baby at home who's in daycare as well? Have there been clusters of group A strep in my hospital? Think about it, do cultures in this population because that's the earliest way to pick up these infections. Let's move on to eclampsia. I show this as a reminder that eclampsia is a vascular condition. In COVID, we've become so much more comfortable managing the vascular complications of disease. And historically, we've only thought of pre-eclampsia being a microvascular condition. It is a micro and a macrovascular condition. The microvascular complications are proteinuria, hypertension, cerebral edema, and coagulation abnormalities. And as a reminder, the diagnosis of pre-eclampsia is any two of the following: hypertension, thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, or any new onset or neurologic or visual disturbances. The harder one to see and diagnose and treat is postpartum hypertension. We miss it. We don't look at the vitals. There are other things going on. We're busy. But look at this case. This is a macrovascular complication of untreated postpartum hypertension. This was a 35-year-old female, G2P2, who presented 4 weeks after a normal spontaneous vaginal delivery. And she described having a headache and weakness for the last 2 weeks. She had presented to 3 other emergency departments and was told that it was a medication side effect or that it was from her epidural. Maybe that was why she was dragging her leg. This patient had a CT that showed a filling defect, went on to have an MRI, and it showed a carotid artery dissection and a vertebral artery dissection. This was a macrovascular complication of isolated postpartum hypertension. At some point along her journey, somebody recognized that she did have hypertension and they started her on a labetalol. I forgot to mention that. But now the guidelines are saying that in pregnancy, this came out in the New England Journal a couple of days ago actually, in pregnancy, our target should be less than 140/90. In our emergency department, for patients who are presenting with symptoms of hypertension, our targets are less than 160/110. Treatments of choice are labetalol, nifedipine, hydralazine, and remember these women have leaky blood vessels, so don't fluid bolus them because of the risk of pulmonary edema. If they have symptoms of preeclampsia or laboratory findings of preeclampsia, our treatments are IV magnesium, huge doses of IV magnesium, 4 grams IV over the first 30 minutes, followed by an infusion. And if they're seizing, it's 2 grams over 5 minutes. We don't see magnesium toxicity very often. It's only 1% of those patients who are being treated for preeclampsia. For those of you who work in rural settings, the key point here is bring an amp of calcium gluconate with you, because if they start experiencing respiratory depression, you're going to give it en route. So just to summarize, we need to use a tool to figure out and help us figure out who's sick in this patient population. Recognize and treat sepsis early. Preeclampsia is associated with both micro and macrovascular complications, and look for and treat those patients with isolated hypertension. Thanks so much, and I'm happy to take questions.